Welcome to the Therapist Thrival Guide. My name is Miranda. I'm a licensed clinical social worker, and I'm here with Heather and Matt. And today we have a really unique topic. This is a brand new one where we're talking about kind of the combination of physical, mental health, and how we can be bridging the gap between these two realms of health. So I'm super excited to have these two guests on today. Heather, do you want to go ahead and introduce yourself first?
Yeah, of course. My name is Heather Olsson. I'm a licensed clinical professional counselor. I'm the clinic director at the Naperville area Ellie Mental Health. It's a suburb of Chicago. Excellent. And we call ourselves the Nellies, the Naperville Ellies. And we are introducing medication management in the state of Illinois, which is very exciting. And this is Matt Toman, and he is actually going to be leading the charge for bringing medication management to Illinois Ellies.
Yeah, so as Heather said, my name is Matt Toman. I am a full practice nurse practitioner, so Illinois does allow us to practice independently. I've been doing it for 8 years now, and I recently joined the Ellie team, and I'm going to be the first person doing medication management in the state. So very exciting opportunity, very exciting times, and we're gonna see how this goes and iron out all the kinks for everybody else to follow in our footsteps.
We should have a disclaimer that we are married.
Yes.
So we do know each other a lot.
Exactly.
Good thing you got an awesome boss.
Yes.
Just saying.
I love that. You two are such a fun duo because, so I'm based in Minnesota, and I've had medication managers or like medication providers, down the hall from me for the entire time that I've been at Ellie. And I can't underscore how helpful it is to have practicing physicians just down the hall that you can go ask questions to, you can make referrals to, you can consult with. I mean, we have like a weekly meeting that we have psychiatrists come to, and so you can ask them questions about medications and just having that service so accessible to therapists and to clients is such a game changer. I'm excited to see more franchises bring that on because it is really cool to be able to offer that. And I think conversations like this are so crucial for therapists to listen to because I think that just understanding how our professions can collaborate is so crucial. I think that prior to coming to Ellie, where, as a therapist in training, as like an LGSW, I never talked to doctors unless I had to. Like I never did. And I think that there was some like intimidation factor of like, they're dealing with that stuff over here. I'll deal with my stuff. Like I never really wanted to venture into more of like the physical health realm. I just was like, I'll just stay in my space. And if we need to collaborate, then that's fine. But like, maybe I'll tell my client that they should really get a physical, if they are worried about certain symptoms. It's like, I'll stay in my lane. And I think that since coming to Ellie, and I worked really closely with several of our other psychiatrists and nurse practitioners, I've realized how helpful it is to actually be able to collaborate and work really closely together. And so I'm excited to dive into this. So as we're talking about bridging the gap, I think that one of the things that Ellie talks about all of the time is that like we're bridging the gap for people who are having accessibility barriers to finding care. They don't have therapy offices in their communities. It's like our whole mission is bridging the gap. But one of the things that you two have talked about is how you're trying to kind of bridge the gap between like mental and physical health care. Can you tell me more about what that means? Like what does that look like, bridging the gap between these two realms?
I think, for me, in my first intake session, I always ask, when's the last time you've had lab work done? Something as simple as that. And usually I get that blank stare, especially, my 20s to 30-year-olds. Well, what do you mean? I'm healthy. I'm young. Why would I do something like that? Absolutely, 100% I understand that. But did you know it's something as simple as we live in the Chicagoland area. If you have very low vitamin D levels, I could possibly think you have depression and you have vitamin D levels and you could take a pill and ta-da, your fatigue goes away.
Such a good example. Oh yeah.
So it's a lot of psychoeducation to our clients about the importance of it. And then also a lot of psychoeducation with the physicians and the nurse practitioners and everybody about, I do have a voice in the room. Please listen to me. I'm going to knock on your door until you answer it. So a lot of persistence on our side of why I'm sending somebody to you for something like this. And then once something does pop up, if it pops up in their lab work, they're more apt to listen. But you can go more into other things, vitamin D, B12, hypothyroid.
Yeah,
Right,
and all the things that Heather is mentioning are relevant because they can give you certain symptoms. You know, if your thyroid function is over or underactive, you can feel like you're in a manic state or you're depressed, depending on which way it's going. And we talk, you had mentioned earlier about the physical health and how before you were not that, cognizant of the intertwining between physical and mental health. And it's, the more we learn about it is you can't have one without the other. So if your physical health is not taken care of, your mental health will not be taken care of, and vice versa.
Oh yeah.
There's all of these studies. There's, there was an Italian study last year, and then there was an Australian study a few years back that show, people with high levels of untreated anxiety are more prone to have autoimmune disorders.
Oh, interesting.
So, it goes back and forth. Like Heather was saying, the vitamin D levels, you live in Minnesota, you know what it's like to only see the sun for 2 months out of the year.
Unfortunately, yep.
So that's our sunlight vitamin. And if you're low, you will feel sluggish and depressed and feel like your brain is in a fog. Now, do I expect the therapist to know what to do about a low vitamin D level? No, absolutely not. But I don't think it's inappropriate for them to say, hey, go talk to your primary, go talk to your psychiatrist, go talk to your provider, get these checked, make sure there's nothing else going on so that we can make progress, meaningful progress, and we're not being hindered by something that we're not even aware of.
I always make the joke, I'm not a doctor, but I like to play one on TV. And so I say, I know just enough to be dangerous. So you have to talk to your doctor. You have to get a consultation. But bring in the results. Let's go over the results. And again, that's on me then for getting the education to know what I'm looking at. Now, can I tell you what A1C stands for? Absolutely not. But I do know the range that they should be in. And then if they are too high or too low, how that's going to affect mood or diabetes, those types of things. But it's being able to have those open and honest conversations with our clients where not everything becomes so scary then. Because a lot of times they don't go to the doctor either because they don't have the resources, the bridging the gap, or because they're too afraid of the results. So if it's bring it together, I can Google with the best of them. And if not, if I don't know what I'm talking about, then I call him. I sign a release. Him and I can talk. I've invited him in the room and said, hey, do you mind if he pops in? And, we had a client recently, PCOS. Let's start talking about PCOS. How does that affect mood? And so just having the access to resources and things like that and knowing something's off. I don't know what that means. I don't have that doctorate degree, and I don't have those student loan bills. So I need to find somebody that does. And so that's when we start, reaching out to our resources.
I love that. I love this conversation because I think that this was something that I didn't think a lot about before having a baby even. Like let me tell you guys, I mean, you may know this about yourselves anyways, but like when I first had my baby, had all of the hormonal changes, it was like I was a different person. I had a whole new level of anxiety. I was like a different person. I couldn't believe how these hormonal shifts and just the lack of sleep, all of these different things that would be traced back to physical health had a tremendous impact on my mental health, had a tremendous impact on how I was treating others, how anxious I was, how, it turns into this vicious cycle of like, I'm not sleeping well because I'm not sleeping well. Or, just it turns into a much bigger deal very quickly. And so I think that since having that experience, and even since then too, having clients who are, menopausal, or I have a client who, I was talking to her a couple weeks ago, and she was talking about how like she's noticed this pattern of whenever she's getting close to her period, then she like, it's almost like she loses all hope and she's feeling really blue and down and depressed. And so even just realizing how some of these different shifts in our physical health have such a tremendous impact on our mental health. Like, I don't think that was something I thought that much about, honestly, before having a baby and seeing that in myself. And so going back to some of these like conversations about lab work, you talked about like vitamin D deficiency. That's something that's really common. I feel like I hear a lot about how your thyroid impacts some of like your mental health. Can we talk a little bit more? I'm curious about more of that. Yeah.
Absolutely. So thyroid function is the main driver of our metabolism in the body. So if you think about it being an engine, if it's underactive, then the engine's running real sluggish and slow. If it's overactive, then the engine's running real, hot and heavy all the time, right? Underactive is much more common, right? And for females in particular, female at birth, I should specify that, they are more common to have thyroid disease than males are. Typically, we also see this pop up usually in like the late 20s, early 30s. And if you think about the average 25 to 35-year-old client, they're probably pretty healthy and not necessarily going to the doctor. Well, let me rephrase that. They're healthy, quote unquote, and not necessarily going to the doctor a lot because they don't feel wrong, right? But they might have that depressed mood that they just can't quite shake. They may feel like they're sluggish, no energy. Maybe they're talking about wanting to lose weight, but they just can't seem to lose weight. These are all signs of an underactive thyroid. Things are all going to negatively impact your mental health.
Well, yeah, we can't lose weight, and then we get depressed about not being able to lose weight, and all of these symptoms can be explained away by something else.
And if your thyroid's underactive, it's going to be really, really hard to lose weight. Could you do it? Yeah. Is it going to be comfortable? Not so much. You're going to have to really work hard, and quite honestly, it's probably beyond most people because now you're fighting against your own body to try and lose the weight. So just making sure that it's, that we've fixed all the physical issues so that we can address the mental health issues and vice versa, right? Because great, so we can fix your physical issues, but if you're not getting the mental health help that you need, then maybe we just start sliding back into these bad habits that we developed while we were, physically still getting worked up and like we call it tuned up.
And if I'm treating it as if it's depression alone, now I'm starting to think it's treatment resistant or something like that. When if we had checked the medical side of things, then we could have worked together and started to come at it from all that integrated health care.
Yes.
And then, then you start trying the medications.
Yeah.
And one of the things that I learned from him, so I'm on it. It's levothyroxine. Say it.
Levothyroxine.
Thank you. So I take it every morning. But also if you get the generic version, which a lot of insurances only take the generics only have to cover what,
82% equivalent.
Yes.
82% bioequivalent. So from a chemical structure, they only have to be 82% the same. That 18% sometimes makes a difference. Actually, levothyroxine is one of the more common medications where people need the brand name Synthroid.
Interesting.
They just need it. And if you're unaware of that,
Right.
and to be quite honest, most lay people are they learn by trial and error that these things happen, not because they read about it somewhere. So they learn about it when it's, oh, hey, my medication's not working quite right. What's going on?
Right.
Yeah.
And so these are the questions that we have to empower our clients to have when, they start taking the levothyroxine and it's been 6 weeks and there's no changes in lab work and things like that. And it's like, okay, are you taking the generic? Are you not taking the generic? Again, not the doctor playing one on TV, but these are some questions that I can empower you to have because most of my clients don't even think of these types of things. They just, oh, this is my prescription. This will make me feel better. I take it I won't say any, to the pharmacy. And then, I go home and I take it. They're being compliant. And why aren't things changing? Why aren't things working? So I think it's important, again, for me to learn these types of things and for the medical community to teach us.
Yes.
Oh, yeah. Especially because I see my clients weekly, and when they get prescribed a new medication or if they are seeing their doctor about a certain issue, they're probably seeing them once a month, once every 3 months, once a year. So there's so many more touch points between you and your therapist. And so even, I like how you say that, Heather, you're enough to be dangerous. You play one on TV, because I think that's so true. I've had so many clients sit on my couch and be like, well, I started meds this week and nothing's changed. And they have no idea that oh, actually, this one might take a couple of weeks to feel a difference.
Right.
Or, they don't understand a lot of these different nuances or things that we've learned in grad school, but then even taking it a step further, I didn't know that generic meds only needed to be 82%. What? That's crazy.
And that goes for SSRIs, that goes for those types of medications too.
Wow.
So if somebody's generic changes and there's a huge change in their mood, I have seen some dire consequences, and they have to go back and get the specific generic one so that insurance can cover it. But they have to have that specific generic brand.
Yeah.
Brand, right?
Yeah.
Brand.
Yes. Or would you just have to up your dose? If you were supposed to be on Celexa and you went on, what would it be, citalopram or something? And then
so there's a couple different ways to approach it. And a lot of it, unfortunately, tends to get dictated by insurance coverage. We'll just call a spade, right? It's, for a lot of the medications. Now, SSRIs are probably not the best example of this because most of them are generic and they're pretty cheap. But if it's, say, citalopram, which is a very commonly used medication, we can either try and get the brand name covered, which, depending on the plan, may or may not require prior authorization, or we can just up the dose, to get achieve the same effect.
Interesting.
The problem is, depending on the dose, upping the dose may not be possible if they're already maxed out, or we might overshoot. And now you're looking at a bunch of side effects, because most side effects tend to be dose dependent. So the higher the dose, the more likely the side effects. So now we might be just introducing more side effects for very minimal benefits in mental health.
Right.
It's always a dance, right?
Yes.
Yeah.
Well, and that's why at least at the Naperville Ellie location, we use GeneSight testing.
Oh, yeah.
Yes. So we use GeneSight testing. You want to explain?
Yeah. So
better than I.
Sure. It's it's a newer test for mutational changes in how people metabolically process different mental health medications, right? So it covers your antidepressants, which are typically your SSRIs, SNRIs, your antipsychotics, your mood stabilizers. We can use the stimulants for ADHD, the non-stimulant ADHD medications, your benzodiazepines, your anxiolytics for sleep aid, kind of all of those. And it'll tell us, hey, you metabolize this normally, go ahead and use it like it's supposed to be. You under or over metabolize this, so you can still use it, but we might need a little bit different dosing. Or, hey, this one is, and it's literally red, yellow, and green.
Mm-hmm.
So if it comes up red, this is hey, you have a significant interaction with this medication. You should steer clear of it because the likelihood is you're not going to get a whole lot of benefit, but you're going to get a whole lot of the side effects.
Mm-hmm. And when you say like metabolize it and, like changing the doses, would it look like let's say I was on some sort of ADHD med and it felt like, I don't know, GeneSight came back and it was like, this is a yellow, like it's working okay for you, but you're metabolizing it really quickly. Would that be a case where like an extended release would be better for you then? Or would it be a different dose entirely?
It could be. ADHD medication in particular tends to be very goal oriented. When do we need the medication? How long do we need it to last for? Is it a child or an adult? So there's a lot of different factors that play into it. So, that's where you really need to have the conversation with the patient and come up with a plan that you're both comfortable with, right? Because you have the immediate release. So maybe, 20 milligrams is not quite enough. 20 milligrams twice a day is not quite enough, but you really only need it during daytime hours while you're at work.
Sure.
So maybe instead of doing 20 twice a day, we change it and we do like 30 once a day, and you take it at 9 o'clock, and then it coasts you through until 3:30, 4 o'clock. And that's all you need it for the day. So that really becomes a conversation with the patient to find out what is most important, what is our goal of treatment, right? Because I think that gets lost with medication management is what is our goal of treatment and what is the likelihood that we're going to cause more problems than good things with the treatment.
Right. Because and I think a lot of that comes into play. There's a medication that shall not be named, but there's a medication that really helps you to go to sleep. But you're so zombie-like the next day that what is the quality of life? Yes, you're able to sleep. Yes, you'll get a good 10 hours.
Yeah.
But then the whole next day, you're so exhausted. And, if a prescriber is only seeing the person once every 30 days, maybe 3 times a year, they're not seeing the quality of life change after, being on the medication. So again, it's making those decisions of, yes, it's hitting the goal.
Yeah.
But what's our ultimate goal is to have a functioning in life, thriving in life.
And you had brought that up earlier as well. You're the point of contact on a weekly basis, and we may see them for 15, maybe 30 minutes once every 3 months if they're pretty stable. So we may not be aware of some of these changes, or they may mask it when they're in the room with us because they don't want to change medications. They've been through this rigmarole and they have more fear of changing medications and having to deal with potential side effects than they do with, sometimes the devil is better than the devil you don't.
Right.
So talking to the therapist who's been with this patient every week for the last 3 months, and they know, hey, their mood has been labile, or they're having hypomanic states, or they're, not telling you about the side effects or some of the side effects that are really bothering them. That's really, really valuable information that they don't always share with us, or maybe they just forget to share with us.
And, to bounce a little bit, that's what helps with knocking on the doors. Luckily, his door is right next to my door. But, before he was next door, I would have to knock on doors with these doctors so that I can build that rapport. So that in a lot of circles, we are just master's levels therapists. We know this. When we walk into a room, I don't have a lab coat or a stethoscope. But, now that I've had so many conversations with so many prescribers and, in the area and things like that, now when I do call and I say, hey, they're not telling you that they're having a hypomanic episode.
Mm-hmm.
Let's be honest, some people, it's a relief to have a hypomanic episode after being depressed and couldn't get out of bed for 3 months. So they're like, you're not stopping this. This is awesome. I'll take the electricity for a while.
Right.
And it's, and it's like, okay, we got to find this happy medium. Or when I start seeing, hey, we need to start having a conversation with your gynecologist, because I think we're past the point of PMS. And I think we're starting to look at some PMDD. And what does that look like? And what does a medication regimen look like there? And having them advocate in that way. Or again, bringing up PCOS. That's a huge one that we have to coordinate care all of the time for PCOS. So just having that education from the providers of what to look out for is key. And then them opening the door to allow me in to say, either physically or metaphorically, but having me say, hey, I'm seeing things. There's a red flag here.
Yeah. Now with PCOS, I am aware of PCOS. I have some loved ones that have it, but curious, like I guess that I only know of like some physical symptoms for them. Like how would you two kind of like collaborate on a case where a client might have PCOS, or what would be some common mental health symptoms around that?
So the biggest one for PCOS from a mental health standpoint is the depression associated with it. That's a very, very common comorbidity. And, depending on the hormone fluctuations, you can get some of those associated changes, hot flashes, whatnot. There's not a ton of evidence to support treating the hormonal fluctuations in PCOS, but that can still be a factor when we treat it from a medication standpoint. And maybe we choose something like an SNRI as opposed to an SSRI because they have a little bit more efficacy with hormonal fluctuations. And if we get something, great. If not, well, that's what the evidence probably says is going to happen anyway, but it's still an effective treatment for the depression anyway. And then coordinating with the therapy team to make sure that, hey, I just started them on this medication. This is what you need to look out for. These are the side effects with it. This is what she's currently experiencing. This is what to follow up on in case I don't see her, because first, as we keep kind of talking about, the therapy team is going to see this person once a week.
Sure.
With a new start of an SSRI or an SNRI, I'll see them in 4 to 6 weeks typically. But they can be experiencing side effects basically after that first week. It's going to start kicking in at that point. Won't be fully kicked in, but it'll start kicking in, and they may be experiencing side effects as soon as, 10 days in.
Well, going back to prior to when you were in the medication management world and you were in family practice, I can't tell you how many people I started having my spidey senses kick in of PCOS. And it wasn't because you go to the gynecologist once a year.
Right.
You go to your, primary care doctor once a year. And I'm seeing you every month. And I'm like, what do you mean you've been, menstruating for 2 weeks straight and you had 1 week off this month? What do you mean? This is not okay. We need to go to the doctor. Well, why? Isn't this how everybody is? Because we don't talk about menstruation. We don't talk about facial hair. We don't talk about those types of things, especially when we're 23. So, a lot of times my spidey senses are the ones that are going off where it's like, we have to start having these conversations. And it was because of providers like Matt in primary care and those types of circles where I would ask questions and I would say, I have a 23-year-old that's literally like getting facial hair. What could that be? I'm like, oh,
super common. Yeah. Yes.
Oh, okay. So, again, empowering our clients, empowering the treatment team. It's no
Mhm.
longer, we're no longer stuck in our offices anymore. That's not the model that we should be following anymore. That's not what's going to benefit the clients.
Oh, absolutely. No, okay, this is just so fascinating. I'm curious too, like when we talk about different lab work, like, different testing things that we can have clients do. We talked about like thyroid, we talked about vitamin D, we talked about like hormonal ones. What are some other ones that you feel like are like if you have a client that's presenting a certain way and maybe things that we could be looking out for and you're like, "Hey, when was the last time you had lab work done or when was the last time you went to the doctor?" Like what would be some other things that we could be looking at?
So vitamin B12 is a big one. If you're really low in B12, you can have almost dementia-like changes. And it's very interesting to see somebody that has a B12 deficiency and the change when you figure out what's going on and you get them back up to, yeah. And those are most common. There's a specific type of anemia called pernicious anemia where patients are unable to absorb vitamin B12 completely, so they have to get the shots. It's also very common in patients who have had bariatric procedures. They have all sorts of
What is a
vitamin.
bariatric procedure?
So, like gastric sleeve or gastric bypass.
Yes. Okay.
So the weight loss surgeries.
Yeah.
So majority of there are certain vitamins and minerals that the majority of the absorption happens in the stomach. So when we have a bariatric procedure where we're bypassing or not
Interesting.
utilizing, 90% of the stomach, then we cut way down on how much we actually absorb. So iron levels would be a big one. B12 levels would be a big one.
Ferritin.
Yeah.
Cortisol. What's the one?
Cortisol. Well, ferritin is the iron levels. So that one can also produce some sluggishness if you're low on it. Cortisol levels that one is our main inflammatory marker. But if you're low, you can also have some sluggishness. That one's a little bit trickier because that's more of an adrenal insufficiency issue. And you're probably talking about endocrine at that point, an endocrinology referral. But
and then cancer, oncology.
Oncology.
I mean, if we want to really start veering off into.
But yeah, just the going back to like the easier blood tests, like our typical like low hanging fruit. We mentioned the B12. The vitamin D, the thyroid function, those are your big ones. In anybody who's got an alcohol issue, which, addiction is a big thing that we deal with in mental health, ammonia levels. So when your ammonia levels get too high, that causes what we call an alcoholic encephalopathy, an alcohol-induced encephalopathy.
What does that mean?
So basically the alcohol levels, there's toxic buildup, a metabolic encephalopathy from alcohol there's this toxic buildup of waste products from the alcohol that essentially causes our brain to short circuit, and we don't think properly anymore. It's a dysfunction of the normal brain functionality. So we don't think clearly. We can't
Does
walk
it
properly.
Memory too?
Yes, memory. It'll affect memory. It'll affect your ability to walk in a straight line. Anybody that's got that, anybody that's been abusing alcohol for a long period of time, they walk with that wide shuffling gait, and that's because of the damage from the alcohol to their brain.
And then
and then the nose, the spider veins along the cheek. Yep. These are all alcohol induced
it can
changes.
We've encountered clients where like in the room, something's just the client isn't remembering the topics that we're talking about from week to week, but the client is, I don't know, 40s, 50s. It's not making sense to me. Help it make sense. And then, was there an alcohol issue?
Yeah.
Well, yeah, why'd you ask? I had no idea about any of this.
Yeah.
And then, we have to get that under control.
Mhm.
And it's life-changing. I mean, obviously we have to get the addiction under control, but also understanding that it's already affecting.
Yeah.
Yeah.
So, okay, we're talking about like some different symptoms. So it might be that you have a client sitting in front of you and they're having memory issues. And that could be a clue into like vitamin B12 deficiency, alcohol issues. Like it could be a lot of different things, but that
Right.
would be a really good time or a symptom to be like, hey, when was the last time you went to the doctor? Other
Yeah.
ones that we had mentioned were like, I'm trying to think of what else we talked about. Memory issues. We talked about, what were some of the other symptoms that we talked about?
Or it's the memory. Do you
Yes.
need to go to the doctor?
Yeah, no kidding. Oh my gosh.
Get a pen and paper.
So fatigue, depression, anxiety,
Mhm.
these are all things that you can and should see your primary care for.
What are some
Matt, I
things
think
you wanna
that's like
talk about
all of
anxiety?
my clients. I mean,
Yeah.
so many clients of mine. I mean, yeah.
So, we all know that from an anxiety standpoint, a combination of medication and therapy is going to produce a synergistic result, right? We're going to get better results with both than we would
Mhm.
expect out of each one individually. For things like SSRIs, SNRIs, things like MDRIs, which are like Wellbutrin, right? These are medications that can be prescribed by primary care, and quite often they do prescribe them. And depending on what the psychiatric services in the area look like, maybe your primary care is the only person you can get in and
Mhm.
see.
Tell the world how many classes in mental health you had in school.
Oh, geez. I think like we cover the mental health medications, but as far as mental health, I am trying to remember if we had a dedicated class at all. So we go by body system,
What?
but so the mental health stuff gets kind of
Mhm.
lumped in with like neurology.
Sure.
There is dedicated psychiatric diagnoses and classes, but
Mhm.
when you start talking about medications, they tend to get lumped into the neurology component because of
Mhm.
how they work on neurotransmitters for the most part.
And
Sure.
with that in mind, it's so, I used to work only with children and adolescents. And so I would start working with, and we're going to say adolescents, and that's when they start going on things like SSRIs and things like
Mhm.
that. Now I understand why the doctors, the pediatricians that were prescribing the medications never talked to my teenagers about how it affects libido, sex drive,
Mm.
sexual dysfunction. Never talked to any of my adolescents about those things. They were never taught how to talk to my
Yes.
adolescents about those
Wow.
things. So now
Yeah.
it's the very first conversation. I had to get
Uh-huh.
over a lot of hangups I had about sex. But now it's the very first thing that I have to talk to them
Yeah.
about. What could this do to your
Mhm.
body?
Mhm.
As a teenager that's just starting,
Yeah.
liking whoever they like. And, it's, again, the more I know about their world, the more I can adjust my world. Are there any labs or presenting things that would lead to higher levels of anxiety? We've talked about depression a lot.
Yeah. So the thyroid, right? If you have an overactive thyroid, your anxiety is probably going to be through the roof
Hmm.
because it's like being on a stimulant all the time.
Interesting.
Now, overactive thyroid,
Mhm.
you won't have the overweight problems.
Correct. You'll more than likely be underweight because you just won't be able to eat enough.
Are there any other symptoms? Like, isn't it hair loss, or is that only hypo?
So both. You can get changes to your hair with hair texture and quality with both hyper or hypo.
Okay.
The big one for hyper is the bulging eyes. That's the one that people
Oh.
seem to notice the most. Is your eyes will literally be bulging out of their sockets.
Okay. I did not know.
That's
I
by
didn't know
far
that.
the easiest one to notice,
Uh-huh.
Okay.
especially when it becomes a problem.
Mhm.
Okay. When I say go get your lab work done,
Yeah.
what's everything that gets done?
So,
good question.
Or do we have to ask for something extra?
you don't necessarily have to ask for anything extra. The big one is talk to your doctor about the symptoms that you're having, and then they should be able to tease out what the appropriate tests to run are. Because we don't need to run every test for every scenario, right? So like the ammonia levels we're only going to run those in somebody with an issue with alcohol use. The thyroid levels, if you've got depressive symptoms, then we're going to want to rule out thyroid, vitamin D, B12, those types of things. You got memory issues, absolutely. We're looking at vitamin B12. We're looking at some other things as well. It's not so much anymore, but untreated syphilis can lead to memory issues.
Interesting.
Untreated syphilis can be very dangerous.
Wow.
And it runs rampant in the elderly community.
Yes.
I remember learning about that in grad school. Yeah,
Yes.
no, I remember that.
in the elderly
community and people with extremely cognitive delays.
Oh, sure.
Yeah.
Interesting.
That are, yes. But it's, so every intake session, when is the last time you had your labs? And then October is my lab month because you're getting really near to your deductible being hit for the year.
Yeah.
So I'm like, go get your labs done. If anything pops up, you still got 2 years to do a follow-up appointment.
2 months, you mean?
2 months.
So yes, thank you. And then so October is always my lab month. If you haven't gotten it done now, go do it now.
Yes, that's such a good tip. No, I love that. Any other things that we feel like we haven't covered in this? This has been so obviously really helpful for me. Like I've learned so much. This is great.
To kind of circle back to what Heather was talking about as far as the side effects, she had mentioned specifically the SSRIs, and this is something that I have encountered multiple times. I do think there's a lot of providers that do disservice to their patients by not talking about the side effects. Because most of the medications that we're using to treat mental health can cause weight gain of some amount, right? Now, this can be anywhere from a couple of pounds to a significant amount, which, depending on what the patient is feeling like and what their body image looks like, that may be compounding an issue as well as treating it, right? So you may just be trading one problem for another. As far as the SSRIs, particularly with the younger clientele, you got to mention the sexual dysfunction side effects. You just have to, and you have to be aware of them as a therapist. You don't necessarily have to know how to offset them, but you do have to be aware that they exist.
Right.
Because if you got your client talking to you about, they lost their sex drive and they recently got placed on Lexapro. Well, now we can put 2 and 2 together and say, oh, that's probably a side effect from the Lexapro. And their doctor probably either forgot or didn't know to tell them that it was a potential side effect.
And see, I would even argue and say, don't wait for them to tell you.
Yeah.
Just bring it up. Just bring it up. What's going to hurt? Because a lot of them won't bring it up because they're just so embarrassed, especially my teenagers. Oh my goodness. Yes. And I'm always like, I'm not asking any personal questions, even if you're in a long time, that's okay, but you still might have problems. And so, we have to have open and honest conversations. And I think we talked a lot about the primary care physicians. Do not discount, gynecologists or OBGYNs, being in contact with them, especially if somebody does have PMDD. If you have somebody that's pregnant, afterwards going through, well, obviously, the postpartum or things like that, but also the PMDD, how do you manage that if they don't want to take medication?
Yeah.
Because now your hormones are everywhere. And it doesn't have to necessarily be postpartum, but it could be the PMDD just really ramping up.
Yeah.
And so, one, it's a really great way to expand your referral sources. I am a CD. We got to get our name out there. But also it's just as good client care. It just is.
Yes.
And your clients, They will never leave you. My clients never leave. And I think a lot of that is attributed to these conversations, open and honest, transparent conversations, and then also being part of a team. I don't know everything, but I will make a phone call and find somebody who does.
Okay, selfish question, because I have a client actually who she is in her mid-20s, and I've been seeing her for a few years. The entire time that I've seen her, she has been on an SSRI. I don't remember which one. But she has, I think for most of her adult life, has had like some sexual dysfunction issues or and this conversation is making me kind of be like, oh, like we haven't really gone down that route because you have always been on this SSRI. But like, are all SSRIs kind of going to be the same, where it's like if you have some side effects on one, then you'll have the same side effects on others? Or is it worth like kind of revisiting and talking to your doctor?
Yeah. So that's a little complicated, right? So the best answer I have is maybe. So all the SSRIs carry the same risk of sexual dysfunction, right? Sexual side effects. Not all of them carry the same level of risk. So escitalopram or Lexapro is the newest, what we call the cleanest version of the medications. So theoretically, it should have the fewest side effects. Does that mean it has no side effects? No, of course not. Can we see somebody switch from one medication to another and then have no side effects? Yes. Is it likely? Probably not, but it's worth a shot.
But they can switch classes and switch over to Wellbutrin.
Absolutely. They can switch classes, or they can add in, depending on what's going on, something, like a dopamine agonist, where we can offset some of the sexual dysfunction side effects from the Lexapro.
Buspar?
Yeah, Buspar is one.
Oh, sure.
Wellbutrin to a certain extent. And then depending on, what other issues we're treating, like Wellbutrin for smokers, for example, will literally bind to the same receptor site in the brain that nicotine does.
Or people that want to lose weight.
Yes.
Wait, so then what does that do?
So you don't have the cravings.
Oh, interesting.
Yeah. So you'll see people cut down from a pack a day to like 5 cigarettes a day after starting Wellbutrin because they just don't get the cravings anymore.
But that's the beauty of some of these medications is that they can treat so many different things.
Yes.
They can treat
like off-label use.
What am I thinking of? Where they can treat beta blockers.
Yes. So beta blockers can clamp down on an adrenaline release, and then you can get some lowered anxiety from that.
Yeah. Boom.
See, this is why we need to be having these conversations. Like, it's so helpful. I mean, I spend every week talking to some of these clients about things that they have just lived with, or that they have, tried this or that or this, and so it's helpful just to kind of relook at some of these different things with new eyes. And also just, I love your tip, Heather, of every October being like, hey, it's lab work month because you've got enough time.
Get my chart out.
Yeah,
get the appointment. Let's go.
Right.
Yes.
Well, and by the time this airs, it's a new year. You've got some new insurance. You kind of start over. Let's get all the lab work done and figure out what's going on. But
right.
No,
but again, add it to your intake.
Yep. Add
it to the intake. When's the last time? Let's go. Let's read it together.
Yeah. And to refer back to the your selfish question about the patient you were talking about, it would be worth exploring exactly when that changed.
Yeah.
Right? Because if she's been on the SSRI the entire time you've been working with her, but that change happened after the SSRI got added, then, and there's not another, factor that we're unaware, and obviously we're not going to go into too much detail here, but
it's worth exploring.
It's absolutely worth exploring.
Depending on, her goals. Some people are like,
I'm good.
I'm fine.
Yeah.
So what? It takes me an extra 10 minutes. I'm good to go. And other people are like, no, this is really affecting my relationship. This is really affecting my quality of life. And it's like, well, then if it's between stopping a medication that makes you feel better or exploring how we can do a Buspar or how we can do a Wellbutrin instead, or how we can do those types of things, is it worth it? At least having the conversation. I've never had anybody say no.
No, this has been such a good conversation, you two. Thank you so much for joining and sharing so much valuable information. I think that this is going to be really helpful to listeners. And
well, thank you for having us.
Thank you.
Yeah, awesome. Well, thank you for listening. And please remember to subscribe so that you get notified for new episodes whenever they drop.